Assalamu alaikum. Dr. Shumala will be discussing about the management of ureteric and bladder stones.
Assalamu alaikum. I'm going to discuss today about the management of ureteric and bladder stone. In this presentation, I will be covering URS and cystolitholepexy. URS, ureteroscopy, is also known as uterorinoscopy, is a procedure in which uteroscope is inserted through the urethra and bladder into the ureter for the diagnosis and treatment of urinary tract problems. Indication of the urolithiasis for non-lower pole stone of less than 20 mm or for lower pole stone of less than 10 mm, in which the ESW is not considered. In the upper tract urothelial cancer, as a diagnostic URS when imaging are equivocal or conservative management is considered. In UPGO and strictures, endopilotomy and ureterotomy can be performed for small strictures. Other indications include the diagnostic ureteroscopy can be performed for persistent unexplained positive cytology, filling defect of excretory urography, and recurrent UTI. Removal of foreign bodies including sutures, proximally migrated ureteral stents, balloon catheters, and other fracture working instrument. For the benign essential hematuria, URS can work as a diagnostic and treatment process. Preoperative preparation include the complete medical history, physical examination, labs, cultures, and imaging, ultrasound, X-ray, IVP, retrograde, pylography, and CT scans. Preoperative preparation continued. In patient preparation, we should confirm that we should stop the anticoagulation 7 to 10 days before the procedure. UTI should be treated by antibiotic according to the sensitivity, and perioperative antibiotic if there's a UTI and pericardial reflux or traumatic procedure should be given. Thrombosis prophylaxis with low molecular weight heparin start from the evening of the procedure. Anesthesia, this procedure can be performed under general anesthesia, spinal anesthesia, and intravenous anesthesia has also been shown to sufficient for distal ureteric stone in females. Patient positioning. Patient is placed in a thotomy position, and supine and lateral decubitus position can also be used for flexible URS. Equipments: cystoscope, ureteroscope, guide wires, ureter dilator, ureteric catheter, ureteral access sheath, stone retrieval devices, stone retropulsion prevention devices, C-arm, contrast, and energy, lithoclast laser, and etc. Ureteroscope, so far we have 4 types of ureteroscope: rigid ureteroscope, semi-rigid, flexible, and digital. Rigid ureteroscope has a large rod lens which is not used nowadays. Semi-rigid ureteroscope uses a fiber optical system which diameter of 4.5 by 6 FR, 6 by 7.5, and 8 by 9.8 FR. It is a working channel of 3 to 6 FR. Flexible URS is used as a digital fiber optic system. It has a deflection of 120 to 170 with a working channel of 3.6 to 4 FR and tip size of 6.75 and 9 FR. Digital URS, it integrates the digital camera light source within the endoscope, and it has diameter of 7.7 to 8.7 FR and deflection of 270 to 275. This is the standard primary deflection and modern semiplex exaggerated deflection. 170 degree of deflection on either side for the 120 to 170 degree of deflection as a primary deflection for flexible URS. Guide wires, we use a guide wire for the establishment of the percutaneous ureteroscopic axis, straightening of ureter, dilatation of ureter and percutaneous tract, stent placement. They are working on safety wires, lubricant wires, and stiffer wires. Ureteric catheter comes in 4 to 6 FR open-ended ureteral catheter, and they are used for exchange of wires, insulation of dye, TOC catheter for dilated tortuous ureter, dual lumen catheter, and post-operative drainage. Ureteral dilatation devices, it has a principle actively, they progressively increase the caliber in catheter of balloon, and passive the ureteral straightening for 3 to 7 days prior to the definitive surgeries. The ureteral dilatation devices are of 3 types: sequential dilators, balloon dilators, and stenting. Intracorporeal lithotripters. Electrohydraulic lithotripsy or shockwave lithotripsy. In this, its working principle in this, the probe deliver a short pulses of electrical spark, creating a bubble that expand and collapse rapidly, and it produces a pressure wave which breaks the stone. Its advantages include it's a cost effective. It can be used with both rigid and flexible URS, and its disadvantages is that it can cause the damage to the ureter mucosa, and it is associated with the ureter perforation. Ultrasonic lithotripsy. The ultrasound probe works by applying electrical energy to excite piezoceramic plate in ultrasound transducer. The plate resonates at a specific frequency and generate a sound wave which create a vibration and that breaks the stone into smaller pieces. Its advantage is that it's safe. There is efficient combination of stone fragmentation and simultaneous fragments removal, and there's a controlled destruction of the stone. Disadvantage is that the rigid nature of ultrasonic probe and smaller diameter limit its application to the management of the ureteral stone. And ureteroscope with straight and relatively large FR is required. Large FR working channel is required to accommodate the hollow piece of the ultrasound probe. Pneumatic or ballistic lithotripsy. It is a metallic rod transmits a pulsatile compression from the compressed air or electromechanical forces. The probe makes a direct contact with the stone and stone fragments due to the inelastic transmission between the stone and probe. Its advantage is that it causes a good fragmentation of the stone and there's low risk of ureteral injury. But its disadvantage is that there's a strong, significant risk of stone retropulsion, and rigid probe are limited to be used with rigid scope. Flexible probe significantly limit the scope deflection. Laser tripsy. It works by the principle of light amplification by stimulated emission of the radiation. It's safe, and flexible quartz fibers can be used with both rigid and flexible ureteroscope, and it is effective for any composition of stone. But its disadvantages is the cost. Laser-based treatment, we have two type of laser, ND-YAG laser and holmium laser, which come in the fiber of 365 microfibers which are used in semi-rigid, and 220 micrometer fibers in flexible scope. ND-YAG laser has a low cost, but its efficacy is low for the hard stone, like calcium oxalate monohydrate and cysteine stone. And holmium YAG laser, it disintegrates all type of stone. It is a gold standard. Its mechanism is thermal decomposition of the stone and thermal expansion of vaporization of water. Holmium YAG laser has a low tissue penetration, so they are less than 0.5 mm, so there are fewer risk of thermal injury, and it has a low risk of stone migration than the ballistic, that is a pneumatic lithotripsy. And laser probe must have a contact with the stone, but if incorrectly used, there is risk of perforation to the ureter and pelvic wall. Laser tripsy approaches: fragmentation and extraction. The laser setting is required for fragmentation, with extraction generally rely upon the combination of energy settings such as 0.6 to 1 joule, along with the rate of 6 to 10 hertz. A common technique is to begin with relatively low energy rate setting and increase only if necessary. Ureteral access sheath may experience the excess fragmentation and subsequent stone clearance. Dusting relies on lower pulse energy and higher pulse frequencies to fragment the stone in debris. When stone is ablated down to the smaller mass, place the laser fiber in the middle calyx and keep discharging the laser as a fragment come into the contact with the fiber. This effect is known as popcorning, and it has advantages that it has a short operative time and there's low risk of ureteral and trauma due to access sheath. In dusting, we have to do the setting of your URS in long pulses, low energy and high frequency. For fragmentation, short pulses, high frequency and low frequency and high energy. And in popcorning, long pulse, high frequency, high energy. Ureteral occluding device, stone cone 2.2F. It is composed of the nitinol wrapped stainless steel wire arranged in concentric coils placed proximal to the calculi before fragmentation. Release stone with a mean force of 0.1 pound. It has advantages to reduce the incidence of residual stone fragment of greater than 3 mm. Ureter occluding device, N-trap 2.8 mesh netting composed of tightly woven nitrile fibers deployed through 3.5 FR catheter placed proximal to the calculi, functioning as a backstop. Release the stone with the mean force of 0.8 pound. Accordion it has a two-part nylon and stainless steel guide wire with the length of polyurethane film attached to the wire section from bottle brush-like obstruction within the ureter lumen, preventing the stone retropulsion. Urogel. Urogel is a thermosensitive polymer solid at the body temperature and liquid at cooler temperature. It is deployed proximal to the stone through a 3 FR ureteral catheter and temporarily occludes the ureter and preventing the stone migration. After lithotripsy, polymer dissolution occurs by irrigation and with the cool saline. These are the devices. Complication of ureteroscopic basketing: avulsion, intussusception, abrasion, perforation, and risk of postoperative stricture and basket breakage or entrapment. Endoirrigation system, we use a dilating. It is used to dilate the ureter and vision during the procedure. There are two methods: active hand pump, Pathfinder bulb, single action pump system syringe, and pressurized irrigation at 300 millimeter of mercury. This is the fluoroscopic equipment. We use this for the ureteral access and monitoring during the endoscopy and stent placement. Benefits of C-arm: it has a greater mobility and improved mobility and less scattering radiation exposure to the surgeon. This is the setup. Video and C-arm monitor on the one side, along with the irrigation, light source, and lithotrite generator, and C-arm on other side. Techniques: cystoscopy, identification of the ureteric orifice, which could be troubleshooting. Ureteric catheter pass up to the respective ureter, and that is cannulated. Then guide wire up to collecting system of the respective kidney. Ureteric catheter ascend over it. Glide wire are replaced with the guide wire. Introduction of instrument and the manipulation. Pressure of the fluid should be managed. Lithoclast introduced and stone is fulgurated. Avoid retropulsion using various techniques on devices and instrument for the stone removal. Then comes DJ or no. Then we'll place DJ, or that depends upon the high risk cases. If patient has a risk of patient has a ureteral injury or chances of edema, patient has a stricture or large residual stone burden, patient has a solitary kidney, renal insufficiency, and coagulopathy. In these cases, we place DJs preferred. And for ureteral edema, DJs placed for 2 to 3 days, and ureteral injury, DJs placed for 4 to 6 weeks. Techniques: for distal and mid-ureteric stone, semi-rigid ureteroscope, stone size, if stone size is greater than 4 mm, holmium laser lithotripsy. If stone size is less than 4 mm, it is removed easily with basket grasper. Proximal ureter, for the proximal and then proximal ureteric stone and flexible URS. Complications include the intraoperative or early complications or late complications that include the bleeding, mucosal injury, false passage formation, thermal injury, ureteral perforation, submucosal or stone loss, ureteral avulsion, and technology failure. Late complications include the renal damage, ureteral stand discomfort, infection, sepsis, BUR, ureteral stricture, and secondary treatment. Post-operative care include the care of anesthetized patient for daycare procedure and oral encourage and mobilization when fully awake. Catheter can be removed. On discharge, that depends. Patient should be discharged on oral analgesia combined with anticholinergic or for bladder spasm, alpha-adrenergic blockers for stent pain, stent-related pain, and counsel the patient about the stent placement and its removal. This is a flexible fiber optic ureteroscope. Digital. Deflection of the tip of the URS. It uses lever system is connected to the deflectable tip via wires. Its range is 180 to 270. सर जो ये डिजिटल है ना, इसमें जो है वो एक ही वो जो इसका सिस्टम है, क्या नाम है, कैमरा सिस्टम और लाइट सोर्स एक ही उसमें इंटीग्रेटेड होता है और इसमें अलग चैनल होते हैं फ्लेक्सिबल में. Unipolar, it rotates the scope to achieve the deflection in different planes. Uniplanar, direction of movement is intuitive and counterintuitive, clockwise or anti-clockwise, and deflection should be guided by fluoroscopy. Precaution using deflection mechanism. Failure of deflection mechanism is the most common cause of scope dysfunction. Scope should not be deflected while inserting the laser fiber. A laser fiber scraps the inner surface of the working channel and create a small rent which increases the overtime and eventually perforates. Do not fire the laser within the working channel. The scope mechanism is damaged. Golden rule is do not step on the pedal if you cannot see the tip of the fiber in contact with the stone. Dilator and access sheath. Use of access sheath for operational during the RIRS. It depends upon the stone load, pelvic calyceal system anatomy. Its sizes are the 9 by 11 FR, 12 by 14 FR. It advantages of access sheath. It facilitates the repeated introduction and withdrawal of the endoscope, minimizes the distal ureteric trauma, wear on URS, and avoid the buildup of pressure in pelvic calyceal system. Its disadvantages of the access sheath is that pre-stenting is required for 2 to 4 weeks due to less spacious ureter and risk of ureter injury. This is the ureteral access sheath. Cystolitholopexy. Cystolitholopexy is the procedure to break up the bladder stone into smaller pieces and remove them endoscopically. There are different terminologies. Cystolithopunch, perurethral cystolithoclast, percutaneous percutaneous suprapubic cystolithotomy, and combined endoscopic approach. Preoperative assessment is all the same as we discussed previously: history, examination, labs, urine analysis, ultrasound, X-rays, AUB. Preoperative preparation, same. Instrument. We use a cystoscope which comes in rigid cystoscope and flexible cystoscope. Fragmentation of the stone by pneumatic lithotripter or ultrasonic lithotripter, electrohydraulic laser, and cystolithopunch. And it can be done under the general anesthesia, spinal anesthesia, and local anesthesia. Flexible cystoscope with laser. Techniques: we will place the patient in lithotomy position. Cystourethropy, we will see for the diameter of the urethral diameter, prostatic lobes, bladder neck, and bladder stone, number of stone, size of stone, and any associated disease. Small stone lavage with cystoscope sheath extracted using forceps or fixation of the ureteroscope loop. A voluminous stone of 200 ml of fluid stone fixed with cystoscope sheath and fragmented.
Elderly patient में especially ना elderly में male patient.
बिल्कुल वो इम्पोर्टेंट है फ्यूचर के लिए कि भाई अगर if he is developing retention again or lower tract symptoms, so you should know कि भाई अगर स्कोपी हम कर ही रहे हैं तो then we should do it properly.
Complication of cystolitholopexy: malfunction of instrument, mechanical lesion on the bladder mucosa, bladder perforation, hyponatremia because of variation or the mucosal damage, intraoperative bleeding, postoperative UTI, and urethral stricture.
Thank you so much.